In patients with high-risk myeloma, I have a goal. And the goal is that if you have a tumor cell that has a nasty cytogenetic abnormality, such as 17p, and you are not able to eradicate this clone, the patient will relapse. Although may respond very well at the beginning, the patient will relapse very soon. Therefore, my goal in high-risk patients is to eradicate the disease, in other terms, to achieve minimal residual disease. And for this purpose, I need to use the best possible treatment. And the best possible treatment is probably a quadruplet, including a monoclonal antibody, proteasome inhibitor, IMiD, and corticosteroids, both for the transplant and non-transplant candidate. But this treatment, that is the optimal treatment for the standard risk, sometimes does not work in the high-risk patients because they show an early relapse. And in fact, high risk not only mean high-risk cytogenetics, also patients that receiving an optimized treatment have an early relapse, or patient that has a poor response to the initial treatment, or patients with extramedullary disease, all of them are high risk. And in these patients that have an early relapse, we need to do an early treatment intervention. It is the term that I like, ERI, early rescue intervention. We should not wait until the patient has a clinical relapse. As soon as have a MRD positivity or biochemical relapse in these patients with high-risk cytogenetics, we need to do an intervention. And I consider that for these patients will be very important, extremely important, to move early the active drugs that we are using at late relapses. And I'm thinking especially on immunotherapy. And I'm thinking in the conjugated antibodies, on the BiTE antibodies, biospecific antibodies, on the CAR-Ts that should be moved into the early relapse or even upfront for the high-risk patients. Because in these patients, the goal is to, as I mentioned, to eradicate residual disease.